25 years ago, patients with scleroderma really had few options. Since then, patients have had improved their outlook. Many have done extremely well, and things are looking up for scleroderma patients. We've got to keep that in mind. And it's in that context that I'm going to look at some of the new stuff that's come to mind. There are now conferences devoted to scleroderma, such as our World Scleroderma Conference. It has 900. I just found out it was 1,200. Okay, good. People and presentations. And we're going to do research and talk about research with redoing of findings and careful, controlled studies.
Scleroderma affects the skin, and this is a typical look of what a hand looks like. So you might notice first that these are swollen. They swell for two reasons. First of all, the little blood vessels get blocked, and that causes water to be pushed out of the blood vessels. The second reason is the body starts laying down more and more mesh, and that's the thickening. Over time then, you can have problems with not getting enough blood, and you'll start getting little capillary bruises, that's little blood vessels. This is the face of someone with scleroderma. There is not one look, but it has some of the characteristic features. So the first thing I told you is there's plugging up of the blood vessels. So look right here, all of these red spots. This is because the blood vessels in the face plugged up, and you basically got cell death there and little hemorrhages, and that leaves scarring. And that's this is after the puffiness, you're left with this. Then the second part is you have a tightening. Now probably the best place to see that is around here. If you look right here and right here, this tissue has shrunk. It pulls into itself. And so it almost looks like a tight mask that somebody has. There's some of that going on right here, a little bit here. Now this can be over just a little area of the body, a partial area of the body, or the entire area of the body. It depends on how severe the illness is for someone. Scleroderma does not have one cause, it has many. Certainly there are genetic factors that can cause this. Also sunlight radiation. Radiation changes cells, so other sorts of nuclear radiation can do that. Pollutions, and then certain medications can do this. Any of these create what's called free radicals. Free radicals are free electrons which damage tissues. And so there's two types of tissue injury that I told you about. One is that there's injury to the inside of the cell. It's called endothelial cell injury. And then the other is that extra things are laid down, the collagen, and this plugs up the inside. So in plugging up, what happens is you can't get enough blood. And when you damage inside, this starts a whole lot of immune system reactions, and you get what are called autoantibodies. Now, the immune system is a beautiful system in the human body. It's supposed to be able to recognize what should be and what shouldn't be in the body. An autoimmune is when the body mistakes the body's own tissue for something that shouldn't be there. And when that happens, it starts creating antibodies, it starts using cells, it starts using chemicals, and the whole point of this is to cause damage. It would be like throwing an IED or a grenade into the body tissue. It just explodes it. Now when that happens, then there are things which come in to plug up holes of the damage. And those are called fibroblasts. And they create these things called collagen. That's the mesh-like tissue. And when that happens, you start to get plugging up of things, and that's when you start to get the thickening of the mesh, and that's called fibrosis. So any of these factors can lead to that, and certainly if you have more than one factor, you're at much more risk.
Next, let's understand the disease a little bit better. The importance of genes and the fact that early and late scleroderma is associated with different proteins which will hint at different treatments. It's based on this idea. That is, There's a genetic susceptibility that can affect the immune system and the vascular system. And on the background of some things going on in the environment, they can be activated and go back and forth, each activating the other, resulting in fibroblast proliferation. Fibroblasts are those cells that kind of support us, but they do more. They produce collagen, and collagen is scleroderma. And that collagen then goes on to cause immune activation, and you get this cycle that we try and break. So now let's get back to genetic susceptibility. So this is a gene. It's part of a chromosome. It just happens to be chromosome 6. And on that chromosome, in each area are these little genes, each one of those little marks down below, and each of those produce proteins. And the proteins are what make our bodies work. So the genes produce the proteins that cause our bodies to work well or not so well. There is a part of our immune system that is very, very early called the innate immune system. That's all the way back. One-celled animals have this, etc. And those are part of the immune system that is primitive but very important for fighting bacteria and viruses. And there are 2 genes associated specifically with scleroderma, associated with that very primitive immune system. And then he also found a gene that's associated with blood vessels, a very important part of scleroderma. So you see, we've begun to find genes associated with various aspects of the immune system. These are called gene signatures. And what you see in this picture is, at the top, all the columns are different, gotta get this straight, different patients. So the columns are different patients, and the rows are different genes. And so you can see that certain groups of patients have that red, that's genes turned on. The green, by the way, is genes turned off, and the black is genes that are inactive. You can see that there are certain genes that cluster for certain patients. And many of those genes in the top group have to do with inflammation. So there are gene signatures for individual patients associated with inflammation. What does that mean? Well, it means that those folks have more inflammation. And consequently, ultimately, we should be able to say, look, you come in, we'll get a little blood, we'll look at your genes, and if they show a lot of inflammation, we treat that. And then, in this particular set of genes, there's a group that are called proliferative. You can see the red ones over in that one section. And patients who have that have a proliferative signature, which means we treat them differently. And then there are those with, for the moment, are normal-like. So genes and gene signatures are going to lead us to individualize therapy for individual patients. So we're not going to have to throw a bunch of drugs at each person. We're going to be able to tailor those drugs. And so this is the first step of getting to that. Let's talk about a new definition of systemic sclerosis. And here it is. It's a classification we just put out last year. And what it does is it quantitates the things we've already been doing. So for example, having skin involvement proximal to these joints up here gives you a score of 9. And all you need is 9 to be defined as having scleroderma. But it also gives certain numbers of points to puffy fingers or Raynaud's or telangiectasia, those little red dots some of us get, and antibodies. And if you add all those up and it comes up to 9, that's the definition. So why is that something different? Well, first of all, doing that has improved what's called the sensitivity and specificity of the diagnosis. You'll see the number 0.8 for 1980 definition, the previous one, and 0.95 for our present one. Sensitivity is how sure we are that no one with the diagnosis is missed. So we may have too many people, some people who don't have the diagnosis, but at least no one was missed. And you can see that the sensitivity is much higher for the new definition, right? And then the other aspect of it is the specificity. How sure are we that everyone that we've identified as having scleroderma really has the diagnosis? Two aspects of the same thing. And you can see that it's very high for the new definition. On to rituximab. Now, many of you already may be on rituximab, but you need to be careful. You saw some of the work on PAH with rituximab yesterday, and if you look carefully, you'll have seen that there aren't controlled trials. So here is one of the trials of rituximab, and it was published in 2012. And what you can see is that the skin score, MRSS, dropped from 13 to 7, indicating a real change. 4 or 5 points is a real change. The pulmonary tests, the forced vital capacity, how well you move air in and out, and the diffusion capacity, how efficient you are at getting oxygen out of the air, were stable. That's probably not bad. Not controlled, remember that, but they did something else. In this trial, they used controls, which are not the best way, but they used controls, patients who were not given the drug. But there's a selection bias here, that's what we call it, where the people who got the rituximab were thought to be the ones who would respond. And the ones who did not were not thought to respond, and consequently, you don't know. But what was interesting, and I think this is the important part of this trial, is on the right, you see that column going down that showed a 38% decrease in the collagen in the skin. So this is a biologic effect that's very real, okay? Compared to control, where there was really 5% change. So that's pretty hopeful. And in the 4 patients who took the drug, the B cells, which is what was affected by the rituximab, decreased and their skin improved. In the 12 patients where the B cells did not decrease, the skin didn't improve. Again, a biologic correlation. It looks like the drug is doing something and it correlates with a clinical response. We still need to do the research, but it's getting there. And those studies are, in fact, ongoing. Now let's talk about stem cells. There are 2 stem cell trials. One in the US called SCOT. We're doing that with a bunch of other centers. And it uses more immunosuppression than the group called ASTIS. That's a European trial. So here's the result. If you look at this carefully, what this looks at is what's called event-free survival. That means you don't need oxygen, you don't need total parenteral nutrition, you don't need dialysis, you didn't die. That's called event-free survival. Okay? And you can see that the patients who had the transplant, the red line, for those of you who are colorblind, the top line, at the end of the period, there's less new events. Events-free survival was higher in the red line, the transplant line, than the blue line, the high-dose cyclophosphamide line. And it's statistical. This was just published. It shows that it works. Now, you look at this in some detail. Look early on in the first year. What do you see in the first year? You see that the red line, the transplant line, had more trouble early on. So transplant's dangerous stuff. And that's reflected in the beginning part of this. But over the longer haul, it looks like transplant works. Now, you never get something for nothing, so here's this part of it. There was an 8% death rate in the transplant group and a 4% death rate in the high-dose Cytoxan group. Okay? So transplant is not for everybody. Transplant is for that 10 or 15% of patients who we can tell are going to do really badly. So don't go to your doctor and say, I want transplant. You got a 10% chance of dying. Okay? Now this is being reproduced in Scott, in the US, so the research will show whether or not it works. We certainly hope it does. ASTIS, the trial you just saw, is a controlled trial done right. I'm on the overview committee for this, and I made damn sure it did. And it was rigorous and transparent. It's only for the most severe, and we need to wait for the Scott trial results. What about TNF? TNF-I, TNF inhibitors, there are 5 of them now for treating rheumatoid arthritis. Okay? So it's available. Is it being used in scleroderma? Well, this is a look at a survey of 79 European centers, 3,000 patients. 2% had used the TNF-I, and they'd used it for polyarthritis, 60% of the people, and for inflammation, and in controlled trials. And did it seem to work in these open trials? Yes. So this is ready for controlled trials.